Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. All right, guys, we are back in action.
Back in action.
We have a guest with us today. Scout came to help.
In honor of March Madness, we brought the most athletic dog that we have.
Oh, he is
with us today. He won't stop moving. So,
although, is he as jumping as athletic as your other dog, or who's the better jumper?
He is the endurance athlete.
Okay,
he could just keep going and going and going. And then Annie, my pit bull, has an insane amount of power. If we're talking about triple jump, Annie. Yeah. We're talking about a 3,200 Scout.
I love that.
Yeah.
Amazing.
Yeah.
All right. Well, yes. For March Madness, the theme of the week, we're going to go over some common basketball injuries and some big injuries that have happened over the past several years in basketball. So
do you think just because you're an orthopedic PA, everybody assumes that you love all sports?
Yes.
Yeah, I think that's true.
Yeah.
I mean, I have my favorites.
Yeah. I certainly don't love all of them. I have a really hard time watching baseball on TV personally.
Yeah. I mean, I think at this time of year, March Madness is fun to watch because the volume is so high.
Yeah. There's something in it for us with the brackets and everything. Well, not for me anymore, but
no, but as a sports fan and a basketball fan, I like watching the game because it's quick. I mean, it's easy to follow whatever. But as a provider, I literally can't watch the injuries happen.
Really?
Yeah. If I see it's happening, it's ad lib. I'm oh my God, when they replay it in slow-mo, I can't watch it. I can't do it.
Do you think that has to do with the fact that you were an athlete? Yeah. And you personally injured yourself?
Yes. Yeah. I
think it's interesting too. A lot of people who go into orthopedics were athletes before. I would say most people.
I think you think I'm speaking, I guess, personally. I think I can relate to athletes better because I've been there. I get their mentality. Whereas I would think if I had a provider that didn't know anything about sports and wasn't athletic looking, I'd be what do they know? We had, when I played college soccer, and we had a person, a trainer or whatever.
Yeah.
And she was ridiculously overweight. And I was come on.
Yeah. That's really hard to stress
you're going to tell
stuff
me what to do. Yeah. If you're someone we talked about the CrossFit people, if I walk into a CrossFit gym and I see someone jacked, I'm this is the gym I need to go to.
Yeah. I want to look like you.
Yeah.
Yeah. I didn't play any, I played some sports when I was young, little team sports or whatever. But once I got to high school, I joined the sports medicine club.
But that's again, if you were my provider, I would be oh my God, their head was in the right place.
Yeah, I went to sports medicine camp one year when I was a junior in high school. Everybody went on cruises and was partying or whatever. And I went to sports medicine camp at William and Mary. Oh my God, it was so exciting. There was a cadaver lab and everything. I was president of our sports medicine club, and I started our National Honor Society for Sports Medicine, and I've never done anything different in my whole life now. So
that's great though. I feel very good about that. Yeah. Actually, my daughter is taking some sports medicine class, and she really likes it. And they have in the area, you can do a 4-day boot camp where you go to Duke ER and they'll take you through. I'm can you sign up for that?
That's so cool.
Yeah. But she's not thinking it's as cool as I think it is, which makes me think that I'm projecting on her, which I probably am.
Yeah. I mean, a little bit.
A little bit. But that, I'm oh my God, you should do that. Would be the coolest thing to do.
But so orthopedics and sports obviously go hand in hand. And March and basketball go hand in hand. So let's chat some common basketball injuries first. So what are the most common things we see? And it's a lot of lower extremity injuries, a lot of ankle injuries.
So right now, actually, last week, we fixed two 14, one was 14, one was 15, tibial tuberosity avulsion fractures, aka patellar tendon ruptures in the skeletal immature. Both were, one was a basketball injury. The other one was a taekwondo situation, but it's the getting ready to jump and explode. And then your patellar tendon / your tibial tuberosity just explodes as well.
Wow.
Yeah. And that's not the first time we've seen that. That unfortunately is I jumped up for the layup. or I jumped up for the rebound, and I came down and I was on the ground.
So that's your skeletally immature.
Skeletally immature.
Athletes, kind of like the traumatic Osgood-Schlatters.
Yes. Yeah.
Versus Osgood-Schlatters being like your chronic, more easily managed.
Yeah.
So what are you doing for those? Do you use like a screw or?
So actually those two we did this past week. So those two, one had avulsed his entire tibial tuberosity off. So put it back down, 2 screws done. The other guy had pulled some of the bone off, but it was more like an actual patellar tendon rupture. So believe it or not, like halfway up the patellar tendon, there was this little piece of bone big enough to put a screw down through. So we ended up screwing that right into the tibial tuberosity, and then just distal did the patellar tendon repair. So it's a hybrid. It was really cool. Yeah.
But those do pretty well rehab.
Yeah, those they will return. They will return to full sport probably in about 4.5 to 6 months. More so the ORIF faster than the patellar tendon repair, just because bone versus soft tissue.
Right.
But
which people always think the opposite. They're like, oh, I didn't break it.
Yeah. But those injuries, those are always surgical.
Yeah.
That's just not like they didn't have a chance to non-op that.
Yeah.
So that's never a great conversation for the kid that's in in season, this is over for you now.
Yeah.
But we will see ACLs, that's a big one, unfortunately, for basketball players. And that's usually on the land. So if they're cutting and twisting, non-contact, jump and land, or you go to pivot, push off that leg and it gives out on you and it's all over from there.
Yeah. A lot of ankle sprains. I don't treat those as often now, but I feel like that was 80% of working in urgent care during basketball season. Football, any season, ankle sprains are just so freaking common.
Yeah.
I was joking with our foot and ankle surgeon. I was like, we should have got you on here for this episode if you knew it had existed. But
you have to know it exists.
You have to know it exists in order to be involved.
But you can watch March Madness weekend and you can count the amount of ankle sprains. I was casually watching last night, and again, this guy came down from a rebound and just landed on the side of his foot.
Yeah,
know that's rough.
Yeah,
but upper extremity, if you're playing a sport where you're catching something throwing at you, you do get some stuff.
Yeah. So I was thinking about, because when I initially did a little outline, it was all lower extremity stuff, ankle sprains, Achilles ruptures, ACL. But I'm like, well, where's the hand stuff? Where's my interest? And we do see quite a few finger injuries. So hyperextension injuries, or the quote unquote jammed finger. My favorite term that people use, I think they just jam their finger.
I love that term.
Yeah. Jamming your finger, mind you, can be as simple as a little mild volar plate sprain, all the way up to something that requires
or something.
Crazy surgery. Yeah. So I mean, a jammed finger you have to be careful with. So common ones, I think we see mallet finger injuries, right, from something hitting the tip of their finger, which do require extensive splinting. And then PIP, either sprains, a volar plate sprain, all the way up to fracture dislocation situations, which we dealt with. I think I was talking about that one last week where we had to do the hemi-hammy.
Yes. But the UCLs too. You'll see a lot of thumb UCLs.
Yeah, thumb UCLs, which we were looking at one of the UNC players injured. I couldn't really find any details on what exactly it was, but it said it was a right thumb injury that initially was diagnosed as a sprain, but it was a misfracture. So I'm kind of assuming it was a UCL injury.
Yeah.
But I don't know. I couldn't really find details on it. But yeah, there definitely are some finger injuries you have to be careful with, because those are the ones I feel like, even as an athletic trainer before I was in this specialty, I'm like, oh, you popped your finger out of place. Let me just pop that back in, tape it. You're going to get back out there and do your thing. Not that I wouldn't do that in the moment still, but the later consequences, I now know to be more dire.
But I think though, it's okay, let's say you were treating a college athlete right now that is in the first, second, third round of playoffs. If they were to jam their finger, let's say x-rays were negative, you tape that bad boy. You let them
totally.
play.
No, you keep playing through it. I mean, this is all, we were just chatting about this. This is all highly dependent on the person's level and the stakes at hand. Yeah. And I think, from a sports medicine perspective versus looking at it purely from a medical perspective, these are very different ways of approaching things.
But even the UNC basketball player, Caleb Wilson, you can't play with a chronically torn UCL. Sorry.
Yeah.
I mean, I guess you could.
Yeah. I mean,
but like for basketball and catching hand, like throwing hand, like shooting hand.
I'm sure there's some, if you have like gross instability, it's going to be a problem. But I also saw a patient a couple weeks ago who was sent to us by our sports med doc and had a complete UCL rupture, like MRI confirmed. I evaluated him and I'm like, it's like really not loose compared to your other side. No pain, full range of motion. I'm like, we're not fixing, we're not fixing this. So I think people can do well with them. If it's not completely unstable.
Yeah. But I think that's also important. Like some injuries for higher level athletes that may be surgical right then and there for the like mediocre population.
Yeah.
Maybe you kind of ride that a little bit further.
Yeah.
And fun fact, Hannah used to be, currently is an athletic trainer.
Okay. Yeah. We can't advertise it anymore.
We can't.
Yeah. I'll get like shunned from the BOC, but no, I was an athletic trainer.
Yeah.
And I just let my certification lapse and I'm having feelings about it. So I may have to reinstate it coming up here soon, but I think it's just a different way of like approaching things because there is a importance factor associated with playing sports versus, the weekend warrior. And, we hate to hear that.
But if you are, a provider, whether that's a PA or an athletic trainer, and you're treating somebody in season from a sports medicine standpoint, you're going to let that person play if they can safely. Mm-hmm. And that's not worldwide in orthopedics. Like I don't think a total joint surgeon would be able to have that conversation with a sports medicine brain in mind, if that makes sense.
Right. Yeah.
Did you think when you were, or do you think even at the collegiate level or when you were an athletic trainer, do you think if someone injured themselves, they like hide it from you or they're like, no, it wasn't that bad. Like, let me get back out there.
I had this conversation on Friday night with our, one of our concussion, doctors. And I was telling him like, we were talking about thresholds of pulling people and stuff because the laws for that change pretty regularly. And I always say my threshold depended on the person and how well I knew the athlete, because if they are top notch, high level, if they're really good, I know they're going to hide stuff. Right? They don't want to not play. Right. So if they report, like if they're telling me even the slightest thing that like gets your radar off, I'm like concerned. I'm like, all right, this is probably serious versus, little Johnny who like doesn't really get to play that much. And I think he actually doesn't want to play because he's not that good and he's not getting like his parents made him sign up for the football team. Right. He's coming over to me and he's like, my head hurts. Like, I'll probably pull him because what does it matter anyway? Yeah. But like, I'm not super, super concerned.
Yeah. But even if you have someone who is very high level, I feel like if someone, like I think you were saying this before, if they're really hurt and they say something to you, like if you haven't communicated with them all season and they're the star player and they come over to you like, hey, I hurt this, that they really hurt it.
It's like the farmer phenomenon in the ER. Yeah. Like the old farmer comes in and he's like, my chest kind of hurts. And everybody's like,
you've had 3 heart attacks. This is your 4th.
Come on. So high level of concern for the high level because they have so much at stake for it. Like they care a lot. So, but speaking of that stuff, we have some like major injuries that we wanted to kind of run through, some of the big ones that have cropped up over the years. So this is the biggest one I always think of. Yeah. Kevin Ware.
Yeah.
Which was 2013. That was 13 years ago?
That was a long time ago.
That was a long time ago, but it was
very
just
different
yesterday.
place in my life. Yeah.
What were you? What place in your life were you here?
No, I think I wasn't even here. I was living in Connecticut, 2 kids, about 6 years into my sports medicine, career or whatever. And I remember seeing this and thinking to myself, like, oh, that was aggressive that they fixed it that night. But now, knowing all the things that I know, I was like, they had no other choice.
Yep.
Like that is something that is emergent. But I remember thinking at the time, like a healthy, what are they? 22-year-olds, right?
Yeah.
Okay. Healthy athletes who come down and land awkwardly enough to suffer an open tib fib fracture. Like there's some underlying things. Like I think to myself, there was probably like a stress fracture that was happening.
Totally.
Yeah.
Like it was in the early stages.
That was not a healthy individual that just so happened to land and the tibia exploded.
Yeah. Yeah. There had to be something brewing prior to that.
Yeah. And you think about it, right? Like these athletes had started their season, November?
Yeah.
And then preseason was before that. And now they're playing, at least, relating to current times, whoever played last night, which is Saturday, also played Tuesday, also played Thursday. You know what I mean?
Yeah. So much.
This is at the time of the season where overuse injuries.
Yes.
There's not a lot of rest happening.
Yeah.
So I think this one was a combination of there probably was something underlying happening, and the way that the player landed just resulted in disaster.
It was disastrous. So that was during the Elite 8 rounds. Yeah. We had already played several games, obviously. I was in undergrad. I was in athletic training program at that time. So that was like a big deal for us. We went to class that morning. We were
what would you do? Yeah. Have you ever seen that one in your rotations too as an athletics trainer?
An open tib fracture? No, I have not. The closest thing I ever saw that was like not quite as detrimental, but could have been. I was working a baseball game for like a summer league, collegiate summer league, and turf field, metal spikes. Apparently that's a bad combination. I was naive to that kind of stuff. I mean, I'm just like walking in and covering. This isn't my team or anything. Yeah. And he like landed weird on his knee. They called me out to eval him. He didn't get up. A little concerning for baseball. Like if somebody goes down in the outfield, he like went up to catch a ball and came down and twisted weird. And so he's got on long pants, and I'm like palpating through his pants, and I'm like, everything feels weird. Like I'm not sure what I'm feeling, but this doesn't feel like a knee. Yeah. Because it was a complete tibiofemoral dislocation.
Yes.
It was crazy. So I was like, why is your kneecap like over? I was like, I have no idea what I'm feeling. So I cut his pants down, and I'm like, holy crap. Yeah. Fortunately, like he had no vascular injuries because of it. It was my personal nightmare because again, I walked in this situation covering, like I knew a little bit about their emergency action plan. I knew that they had a gate where the EMS could come in through. So I call EMS, or I have somebody else call EMS. I'm like checking his pulses and everything. And they're like, we can't find the key to let EMS in the gate. I'm like, get it the fuck together right now, guys.
Well, it's crazy though, because like, you're there and the plan is call EMS, but like how many times does that really happen?
They call EMS.
Right.
I mean,
enough times where they don't know where the key is, right?
Yeah. Like, there. But yeah, I've never seen anything to that extent. I mean, the basic principles of it. I mean, obviously they like covered it up really fast, whatever. Yeah. They're gonna have to irrigate the shit out of that anyway in the OR. He ended up getting an IM nail that night.
But open fractures. I mean, I played with a girl in college who went in for like she went in for a tackle with the goalie and she broke her tibia, but that was a closed fracture. I mean, it's like, Lindsey Vonn versus open. Yeah. When you have an open tib-fib fracture, the bone is through the skin. Like that immediately is a contaminated surgical site. So if we were to see that, one, we probably wouldn't walk into our clinic, but neurovascular structures, you have to make sure they're okay. You need to get that reduced ASAP. Like that's not something you can go home and like maybe come in the next day. Yeah. Like not going to happen. So that player straight to the hospital, straight to surgery, so irrigate the crap out of that, rod that, not walking on it for 4 weeks.
I'm sure. Yeah.
Yeah. And then that, the atrophy that happens in the lower leg and learning to walk again and then getting all the muscle strength, like that's a 6 to 9 month recovery.
Yeah. Even for somebody that elite who's like arguably you're doing things as quickly as they're getting rehab every single day as opposed to once or twice a week. Yeah. For our weekend warrior outpatient setting person.
But it's super crazy though. Like that happens in the middle of the game. And then, athletic trainer, coaches, medical staff, EMS, patient goes off the court. Okay, let's return to play. Like what?
Yeah.
That's crazy.
Wild.
Yeah. So that happens. And then you just kind of get the old broom out on the floor and then you finish the game. Yeah. So
let's move on. And now everybody from a other player's perspective, like mentally that messes with you. You're like, one, distraught because like that just happened to your teammate or whatever. And like the cost of like how that's going to
Losing
affect
them.
that. Yeah. And then like also the fear of like, am I about to shatter the shit out of my leg when I jump up?
But like, also like this is like so relevant for even like the life you and I live. Like you're the best player until you get hurt, and then guess what? The sub just comes on and the game goes on.
No.
Like you are
handle
replaceable.
that. No, I hate that. I can't think
like
about that.
Your
No.
unfortunate circumstance opened the door for somebody else.
Somebody else. I know, but like, can we talk about the fact that maybe they're not completely replaceable? Maybe like maybe they were better.
They were better. That's why they started, and that's why they played.
Oh, and then like you wonder, are they going to get back to it? Will they ever be their old self again?
Open tib fib fractures, and again, Lindsey Vonn, not open but closed tib fib, like that requires a tremendous amount of surgical fixation. It's traumatizing, but it doesn't affect a joint.
Yeah,
like it's not the ankle and it's not the knee. Theoretically, as long as that heals okay, they should be able to get back to everything.
Yeah. But like the phenomenon mentally of it, like I was talking about the box jumps.
Warfare.
Yeah. The box jumps. I can't do a box jump anymore. But.
Yeah. I don't know that player would want to, like if there's, a 50-50 ball and you're going for it, like maybe you don't.
Yeah.
Maybe you don't.
Yeah.
Just kind of let that
crazy.
Go. Yeah.
I mean, I would say that's arguably like the biggest, most like traumatic one that was aired. Yeah. And then I was looking at other ones. So Kevin Durant in 2019, Achilles rupture. I don't really like have too much recollection of that. Maybe I just like wasn't paying attention
I feel
to
like
things that year in my life.
No, but when those happen, they don't look as traumatic.
Yeah, like, and Achilles ruptures to me, I'm like, we see them a lot.
Yeah, but again, it's season ending.
It is. Yeah.
Achilles ruptures, let's talk about that for a minute. So if you rupture your Achilles tendon, and again, let's not talk about elite athletes. If you fix them, they have a 25% failure rate. That's really high.
That's crazy.
If you don't fix them, they have a 25% rate of re-rupture. Like think about that for a second. I play soccer with this guy. He is a big dude. He's like 6'4", and he ruptured his Achilles tendon again playing soccer, and he didn't fix it. And it got diagnosed super late. Won't talk about that. But he's back out there playing, and I see this guy cutting and moving, and I'm like, how?
Yeah.
How did? And again, this is not 6 to 9 months later. This is like a full year and a half later. But if an elite athlete, again, explosive, quick turning, healthy Achilles tendons don't rupture.
Yeah.
Right.
Yeah.
So you've got chronic Achilles tendonitis. Maybe you've got tight calves. Maybe your warm up and recovery is not great. And then you explode change directions once and pop. If you've ever seen one or heard one, it sounds like a gunshot. And you're like, where did that come from? Wow. My roommate in college, she played soccer too, ruptured her Achilles tendon after taking Cipro. Which is
big risk factor.
Yeah, which is one of those risk factors. But in a otherwise healthy 20-something-year-old female, like that doesn't happen. Yeah, Achilles tendon ruptures much more common in males than females. But I won't say, one, it's not a surgical emergency. Yeah. Two, it usually is surgical for a elite athlete. But again, the recovery, at least what we do, we serial cast them in plantar flexion, like where it is appropriate, have them come back in a week and put them more into neutral until they can walk on that. Yeah. You can boot those, you can cast those, but those are lengthy recoveries. Yeah. Those are lengthy. And the atrophy that happens in the calf is ridiculous. Yeah. Ridiculous. So again, usually season ending when it is an Achilles tendon injury.
So from a usable information. There's a word I'm looking for.
I'm ready for it. I think most of what we talk about is usable information.
Application based. Okay. Here we go. For application of this, like what would we say? Let's talk about like what you do in managing these things from an ortho clinic perspective, like it walks into your urgent care or whatnot. Because, unfortunately for most of us, or I don't know why I said unfortunately, but we're not dealing with these high level athletes. Yeah. This is a different population, generally speaking, we're dealing with. Now you're going to have your higher level athletes, relatively speaking. We take care of a lot of the local high school teams and some of the college teams around the area. And you may have some of the weekend warriors who feel as though they
pickleball
are
Achilles tendon.
The elite. So management of these things. Achilles, typically they walk in,
or they
felt
don't walk
a massive,
in. No,
they don't walk in,
no,
they limp in.
Normally they limp in, or they're in a wheelchair. They feel a pop. It's like after they exploded, they hear it. They look around to see what that sound was. Then they realize they can't push off. So when you see these acutely, they have a defect in the Achilles tendon. It's usually myotendinous junction, hopefully more distal than proximal, so you can fix it. But Thompson's test, lay them on their stomach, squeeze their calf. If there's no motion in their foot, then that's not connected.
Yep.
I will tell our urgent care the best tool that you have, again, should be your physical exam, but again, provider dependent.
Yeah.
Ultrasound it.
Yeah.
Yeah. Just have them lay on their stomach and the foot just flops into plantar flexion and ultrasound it. And you can literally see the gap. Those that are like, wasn't it? Was it a calf? Is it the Achilles? Like where exactly is that? Stat MRI, that's usually the diagnostic test of choice, especially if you don't have ultrasound available. But you're looking at where it tore. Is it, off of the actual calcaneus? Is it more mid-substance? Is it myotendinous? Is it their calf? Like, is it so high up that it's their calf? And then, depending on where they are in life and what their, age, level of sport, level of physical activity, you either fix it or you don't. But shout out to Arthrex. They've got this really cool PARS jig, which is this crazy,
so cool. Yeah. Cool.
Way to fix these. And they do really, really well.
Yeah. I've seen that once.
Yeah. We did that a couple times, but that was cool. A really cool thing.
And then I would say
hold on. DVT prophylaxis. My God. If these are so swollen and then they're non-weight bearing, right?
Yes.
Or at least they're weight bearing in a boot. Huge risk of a DVT. So guess what you can't operate on? People that have blood clots, or at least not advised. Some people do, but yeah, DVT prophylaxis.
Yeah. What do you do? Aspirin, or do you do something more aggressive?
No, like aspirin 325. Yeah. Especially if they're, usually they're athletes and they're non-weight bearing. Even if you tell them they can, they're just not.
Boot versus splint kind of thing. I think that's provider dependent for what the person uses post-op protocol wise.
If I know it's torn, I'll boot them maybe with a couple heel wedges in there. But yeah.
Ankle sprain is probably the most common thing that we see walk in. Highly dependent on how people treat these. And I think there's this is one of those things that there's not one set right or wrong answer. There is, depending on the doc that you're working with that you talk to, they have a right and a wrong answer, but that's variable among people and what their threshold is for these, immobilization wise and rehab wise.
But what's crazy about ankle sprains is I feel like you can have someone who has a traumatic, inversion, felt a pop, immediate swelling, can't walk. And you can have someone who does the same thing, plays the rest of the game. They wake up the next morning and it's massive. And you can look at the x-ray. It's the same. Nothing's broken. Right? It's usually the ATFL laterally. If it involves any type of deltoid, usually those take longer to heal, longer to get back. But these present with a little bit of swelling, sometimes massive swelling and bruising.
So dramatic.
They can look terrible.
Yeah, they'll literally come in. I've had people come into urgent care walking on it, massive, purple.
Yeah.
Negative x-rays.
Yeah.
And they're moving it fine. They're like, it hurts a little bit. Yeah. I'm like, oh, wow, impressive. And then I've had girls come in on the wheelchair, can't weight bear, very minimal, if any, swelling, totally different presentation. So,
but the ankle sprains that happen when you're running and you kind of just hit the ground funny.
And what happened to you today?
To me an hour ago. Those ones where you invert real quick and then it just boomerangs back.
Yeah.
Those ones I feel I don't know. I feel like when someone says in the 5 minutes after it happened, could you walk and could you do things? That will help me predict how to treat them.
Right.
Versus those that I can't walk. And I'm that's going to be a long recovery.
Yeah.
But the number one question that patients will ask when they come in with an ankle sprain, when can I get back? It literally depends.
Depends.
Sometimes it's a week, sometimes it's 8 weeks. And they all rehab and recover so differently.
Yeah. And the rehab is super important for it too, because these chronic ankle sprains, these chronic repetitive ankle sprains and chronic laxity, leading you more predisposed to getting them. So definitely appropriate rehab balance training is super important.
Yeah.
But I'm doing the same. Usually if they can't weight bear, right, they're getting crutches or they're getting some sort of more extensive immobilization versus the person who can, they might get a brace or an ACE wrap and
Yeah.
much earlier rehab.
Yeah.
So-
But I like to treat these, especially if it's an athlete, like encourage them to walk on that.
Yeah.
But again, you're dealing with a population that will feel comfortable with that or not. And you
Yeah.
know that some, they just need permission to, and then they're good to go.
Yeah.
Whereas some, you're like, no, you can walk on it. Like, no, I'm not going to do that.
Yeah.
Well, that's going to take a long time to get better.
Yeah. And then like 3 weeks later, they come in for a follow-up
Yeah.
and they're like
Yeah. Miserable.
incapacitated. Yeah.
I'll tell you what I do like, the old ASO brace.
Yep.
Love that brace. It's like a little lace up figure of 8 situation.
Yeah, I like there's a, what's the name of that one? One of our docs here used to use it more for his soccer athletes. It's more like got a neoprene sleeve and it's got the same concept as the ASO without the laces because I hated
bulky.
Yeah,
bulky.
the laces were bulky.
Yeah.
And like I would have to sit there like I was lacing a Converse, like staring at the patient, like
like you're a
nothing.
shoe salesman. You're like, okay, let me start at the bottom.
Yeah, like put your foot right here up on my thigh and I'm lacing it up.
Like Al Bundy. Like, here we go. Yeah. But no, they're bulky though too. Like to get into a basketball shoe, fine. To get into a soccer cleat, ugh, a little tough.
I like taping better.
What about
that.
taping?
Yeah. Fan of taping. Oh my gosh, we could do a whole episode on athletic trainers' preferences on or thoughts on spatting, on taping over the shoes. But yeah, no, I think for certain athletes, like taping is much more functional. It's not quite as rigid depending on the techniques that you use and the supplies that you use. But yeah.
So what's crazy
I'll
though
still tape
about
an ankle. I don't know if I can.
how fast can you tape an ankle?
Now?
Yeah. Oh, no, in your prime.
In my prime, I don't know. We did a timed situation. I remember like my fourth year of athletic training was all like just, messing around, like fun times. So we definitely all timed ourselves for ankle taping. And we did it blindfolded one day. I vividly remember my program director, he was like, I can tape an ankle in X amount of time blindfolded. And literally like we blindfolded him.
Did he do it?
Yeah, he did it. Yeah,
great.
It was great. Yeah. No, he did a great job. It was hilarious. But yeah, I'm sure in my prime, quickly and well, today, I don't know. That's like, I'm going to have to practice or I'm going to have to see what I still have. Yeah, try it out. And then based on that, I will make my decision if I recertify myself or not.
There you go.
Yeah,
well, return to play after ankle sprains, highly variable. I think I encourage early weight bearing, early mobility, early physical therapy, rebalance, training, strength, get back into impact as soon as you have all the foundational things. Now, patients will ask for MRIs. Especially because when you take the x-ray and they expect it's broken because it looks so terrible and it's not. Let's say you get an MRI scan, ATFL, grade 2 or 3 sprain, aka partially torn or fully torn. Guess what?
You can still
it doesn't matter.
It
doesn't matter.
You still non-op all of these, and initially at least.
So when, and again, in your urgent care brain, when would you suggest a patient would maybe need to see the foot and ankle surgeon for surgery?
For surgery?
Yeah,
I will never say the words to somebody with a grade 1, 2, or 3 lateral ankle sprain that they need surgery 100%. Yeah. However, I will recommend that they follow up with them at some point and then we'll figure it out based on that. So,
but your repetitive ankle sprains where they're walking on an uneven surface and you can't even they sprain their ankle just looking at an uneven sidewalk. Yeah. Those that have recurrent instability, they sprain their ankle 500 times. Now it's atraumatic. They probably have EDS, right? Like those patients, you can talk to about doing like a Brostrom procedure for stabilization, but
I tell them like the majority, these are all non-op until they're not, which is very rare.
Yeah.
I mean, the only time that I'm setting someone up and teeing up for surgery is if they have like Weber fracture, syndesmosis injury, something like that, then we're doing that. But yeah, well, this was good. I think we've hit on some very important basketball topics, and I hope everybody enjoys watching the remainder of the tournament.
And hopefully no significant injuries because I can't watch them.
Yeah, if not, we'll have to talk about it next time. So I hope not. I'm knock on wood. All right, till next time.
Bye. Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.